Myself, Dr. Sunil Alexander, Secretary of Smart City Branch. I welcome you all to the 15th CD program of this year. This year, we had all our CD programs as webinar only. And today we are having an eminent speaker to speak to us about the sterilization protocol and are we really protected in our PP kits, etc. Dr. Vinith will give us a wonderful lecture, I suppose. I request Dr. Deepak to introduce the speaker.
Thank you, Sunil sir. Good evening, one and all. I'm very happy to introduce the speaker for the day for the 15th CD program by ADS Smart City. And the speaker for the day is Dr. Vineet Panti. He completed his graduation in the year 2008 from YMT Dental College, Navi Mumbai. He further pursued MDS in oral and maxillofacial surgery in the year 2012. He is an active member of the Indian Society of Oral Implantology and is conferred fellowship in implantology in the year 2017. He has been practicing as an oral surgeon and implantologist since 2012. He is on panel with various hospitals like Surya Hospitals, Santa Cruz, Criticare Hospital in Andheri, Millet Hospital, Jogeshwari, Hindu Sabha Hospital, Gadopar. He is a consultant oral surgeon and implantologist at various clinics across Mumbai city. Dr. Vineet has presented papers at various national symposiums and attended specialty training programs and conferences to further enhance his surgical knowledge regarding implantology and advanced bone grafting techniques. So we invite you on this occasion and we expect a great session from you. A lot of members are waiting for your excellent session.
Thank you so much, Dr. Deepak and Dr. Sunil. Good evening to one and all. Dr. Vineet here. I would just share my presentation. Am I audible and is it seen to everyone?
Yes, sir.
Yeah. Good evening, one and all. Myself, Dr. Vineet Pandey from Mumbai. So, on a good October 1st week, first Monday, we are here discussing something really basic that we all follow in our respective clinics, in our respective setups, and something that we should be really taking care of. Last year, during same time, we were quite affected with COVID-19 virus. And during the time we were all home, we had multiple tutors teaching us about the various protocols that we should be taking care of in our clinic and otherwise. We did listen to all of them. We made our notes and there we were. But some of us were really scared to step out. We got really paranoid with the virus and the spread all around. So we tried to stay indoors as much as we can. But some of us were really comfortable in the PPE kits and roaming around everywhere. Gradually, we had to be comfortable in this suit for all of us. Then comes a time that we were sitting and we really got bored of listening to everyone and we decided that enough is enough. We need to now get back to our clinics and back to our practice. Patients are waiting. So we need to get back and we started preparing with everything that we heard on the webinars, all the products which are available without even thinking how is the future use of each and every, but we just had to install things. We had to get into a coverall from head to toe to everywhere, oxygen supplies inside. We marked our clinics for donning and the doffing area as big as our clinic was, but still we tried and make some reservation for the areas to change. Some of us are really short of doing this, installing the gas machines outside our clinic. But let's get practical. It's your clinic. You got to decide how much you can install where and how do we go about it. So we need to think little practically as well. I'm a clinician. I'll be not talking about much of the academics and the disease otherwise, but we need to know what we should do in our clinic. So there comes infection control in our clinic. Basically, there is a triad. So when the host is susceptible, the virulence of organism is high and the organism gets a portal of entry into the host. That's where you contact an infection. So we need to tackle these. So we know the regular ones, the most susceptible ones, hepatitis, tuberculosis, HIV. We heard all this. We have to be protected against these diseases ourselves. We can take vaccinations for hepatitis. We take all the protocols for when we initially pre-COVID, when we had an HIV patient, we used to wear our something similar to PPE kits now. There was an HIV kit. Tuberculosis, we know when patient is coughing and we need to stay away. So we need to be safe from all this. Contact diseases also like herpes, measles, mumps. We need not examine such patients directly without gloves. Of course, things have changed after COVID. So the transmission of these diseases is directly, like from patient to the dentist, or from the dentist to the patient, or from patient to patient. So we need to block this portal of entry. So to prevent patient to dentist and from dentist to patient, we have PPE kits which are available now. We have face masks, headgears, hand gloves. So we need to protect ourselves so that we don't transfer it to the patient. At the same time, we don't take it from the patient. So we need to block this portal of entry. Washing hands on and off, I'll be mentioning throughout my talk. It's the most important thing. We all have heard that washing hands with soap will kill the COVID-19 virus to quite an extent. Of course, it's not 100%, but it's to quite an extent. So we need to block this. Hence, we need to wash hands clearly. And like you can see in this small videos that will be coming through, we need to scrub our hands really properly. To prevent transfer from patient to patient, one of the most common mode is injections. Like if we use a multi-dose vial and we are repeatedly filling our syringes from that, that is one of the modes of transfer. We need to get 2 cartridges and syringes. I'm sure most of our clinics of the clinicians who are attending are not equipped with cartridges, but it's time, it's the era that we shift to it now. Virulence of organism, I'll be talking about this through the webinar as well on how important is sterilization, but we need to reduce the load of organism. Hence, our body can fight this and we'll not get the disease and we'll not spread it ahead. So coming to infection control, we know all these diseases can happen to us. So how do we take care of it? We heard everything last year, all the precautions taken, but it's just not enough. Our staff was not listening to all these webinars. So we need to train our staff because they are the ones who are equally going to play a major role in this. So we need to make sure that they are equally trained for the same. How many of our clinics look like this pre-COVID? Like we had long appointments waiting out, we had few of people outside, we had all sorts of games for our pediatric patients, we had some magazines out there. But that's where I come to advantages of COVID era. So due to COVID, we have stuck to appointments. We would see patients only by appointments and we would not take any major walk-ins unless they are in terrible pain. We need to declutter our working area and the waiting area. We need to not keep those magazines for patients to sit out and read. They'll all carry the virus. We've started taking history so seriously. It was always supposed to be taken, but we never took it initially. As the patient walks in, we directly take on chair, okay, you have a toothache, your tooth is badly decayed, let's remove it. No, so history taking, be it for COVID because of travel or otherwise, if diabetic patients, and we started monitoring all of them on call, on first appointment call that they take, we always ask them, are you medically compromised or not? And we have been sending consents on digital media so that they can sign, read and come. And then when they come to our clinic, we check the saturation levels and temperature checks. So all this was supposed to be done even pre-COVID, but thanks to COVID, it has now come as an eye-opener. As the patient sits, we need to drape the patient. We need to give patients a proper oral mouthwash rinse so that basic load is reduced. Basically, the organism will not go completely, but at least the load will reduce. So it's important. Respirators and shields, they were also supposed to be worn. I don't know how many of us really wore shields before COVID era. We need to be protected with the aerosols from scaling, from aerotorules which are coming. And mask should be worn properly, not as seen on the chin. When we examine the patient also, we need to have it on our nose and mouth. Scrubbing, This is not only for surgeons who are going to the OT or someone who's doing a major surgical work anywhere around. This is basic scrubbing protocol that we should be doing when we are doing a longer case or when we are doing an implant surgery or when we are doing bone grafting. Properly, we should be scrubbing our hands up to the elbow because that's where your gown is going to be covered with and you can glove up and you will be protected. PPEs we can wear whichever you are comfortable in, but it's just supposed to be covering you and you should be protected, your patient should be protected. Be it a PPE or be it a gown, which is a coverall gown, either of them properly worn will safeguard you from any of these bacteria and viruses. So we need to be comfortable because we are working in the mouth, we'll be taking longer procedures, so we need to be comfortable as well. So how would you be wearing the gown? You will always have your assistant behind you to tie the gown because once you wash your hand, you'll not be able to go behind your back and close the knot. So you need to have an assistant there and you need to wear glove in such a way that it's covering the cuff of the gown because if it's not covering, it is not tight enough and there'll be a space there from which the bacteria and the virus can get in. So the first glove is worn in this way. So when you're wearing a PP, that's how you tie it and you wear a full coverall with hijab on your head or whatever suits you. But that's the order in which you wear it and you cover it with a plastic gown if you want to use the same PP over multiple patients, but ideally that's not recommended. Scrubbing and draping, even when you are seeing a patient just for a checkup, just for an OPD or just to prescribe some medication, always drape your patient. Undraped patient is always a scare to your clinic, to you for the infection. So you should be doing that. And when you're scrubbing the patient for something major, like for implants or bone grafting or something, you need to scrub the entire area under the nose up to the neck. Because invariably, I don't know, once you see when you're observing yourself working on the patient, you'll see your forearm is touching the forehead and so on and so forth. So you should be scrubbing the areas which you are going to contact and see to it that it is maintained clean. Sterilized instruments. How many clinics would be using these packed instruments? And once the instrument is packed, the assistant feels that, oh, it's the sterilized instrument. So the pack is directly kept on the green cloth on the trolley. No, the instrument is sterilized, but the packet then when kept in your storage space is unsterile. So you have to guide your assistant that open the packet and put the instrument. You have to drop the instrument on the green cloth. That's where it maintains 100% sterilization. The packet has been touched multiple times. It is unsterile. So you cannot put it on a sterile cloth. We need to train our assistants for this. Many of us are still not used to doing the scoop technique to cover the needle. Many people are not even covering the needle after the LA is given. We need to stop that. The unprotected needle can poke you, your assistant, or the patient also at times, and it can lead to spread of infection with the puncture problems. So we need to learn this technique, the scoop technique, as it's called, to cover the needle and stay protected. No two hands to be used to cover the open needle. It's really risky. I'm sure most of us would have experienced it also. Work with all the protocol in place. Extraoral suction devices are useful when you're doing an aerosol procedure and wear the shields properly. You need to cover it, you need to be safe, otherwise these aerosols can enter from crevices. So we need to be protected. Give patients an eye cover, eyewear, so that even their eyes are protected, and a shield for the assistant as well. And once the procedure is done, we remove the gloves, we remove the PPE or the covered plastic apron on it, and we remove the head cap and the shield, and we discard it directly into the bin. We don't reuse generally because we don't want viruses to be transferred from one patient to the other. So COVID era has given us a lot of eye-opening procedures. We need to clean the dental chair, which comes under clinical contact area. So all the areas where you have touched or your assistant has touched or the patient has touched are all infected. That comes under the clinical contact area. While doing a clinical procedure, you touch these areas. So they have to be cleaned with algae-free. Algae-free is an aldehyde-based scrub solution and has a good fragrance as well. So you can clean it and your instrument, your chair and the operative chair and the trays around will not get corroded, but at the same time they'll be cleaned. The housekeeping staff which you have will clear all the other areas at the basin, at the table or anywhere around in the waiting area. They'll mop and clean all the housekeeping areas which are away from the dental chair and directly not in contact with you or the patient. Handling of these sharp instruments, a very important point to be noted that the sharp instruments, the needles, the blades, they have to be discarded in the dental room itself. Next to the chair, when you have a non-PVC container where you can directly drop the needles, should be the ideal way to discard a sharp item. And along with these sharps, you should also discard a single-use instrument like the syringes. After you break the needle, you burn the needle, you have to discard it in the room itself, and it should not be going to the sterilization room. And the instruments which have been used, they should be packed into the respective cassettes or on the kidney tray or the bigger trays, and they have to be transferred to the sterilization room or a dedicated area in your clinic where you have your autoclave and all the cleaning procedures done. And be safe that these instruments should not fall on the way or they should not be spoiling around. Room disinfection. So this is what even I follow in my clinic. UVC towers have been recently come for the clinics, but they were always in use for operation theaters and in hospitals. UVC, like we have UVA, UVB, and UVC. So UVC is one which acts on the outer layer of the virus and the bacteria where there are proteins. So it disrupts this outer layer and that inactivates this virus. But there is a specific wavelength that we need to be sure of. So somewhere between 200 to 300 Newton meters should be the wavelength, and 254 is the peak at which your UV tower will work efficiently. So depending on the area that you have, you need to design your UV towers. We do get UV towers with 2 tubes and 3 tubes. They are generally enough for 100 square feet area. So once you sterilize that area, then you can shift it to the other room, to the third room, and that's how we do it in our practice. But be careful, you are not supposed to be in the room where UV tower has been on and it's been activated because it can damage the skin. You can get skin burns and your eyes can get damaged. So the minute UV tower has started, you need to move out of the room. You also get Bluetooth switches. So once you're out, just start the switch with your cell phone and the UV tower will start. We need to be protected. So a short video on what we do when a patient walks into my clinic setup. So generally they get x-rays or some background. Of course, we tell them not to go anywhere and come. So they directly come, we sanitize, we take their temperature and the saturation levels. Once seen, all okay, they are noted down on the consent which is taken for COVID, clean, sterile instruments which have been kept. Air purifier, of course, it has multiple advantages, not only in COVID, but even back in your clinic, once you see, you'll see how much dust is there. As the procedure is done, the patient is out, all out from the operating area, and the UV tower is on. This UV tower stays for 5 minutes from my 100 square feet room. The doors closed and entire air and all the surface areas have been sterilized. Post the UV light, assistant will mop and clean the clinical contact areas like I mentioned. Be mopped and cleaned with the algae-free solution. The light is not to be forgotten, and also the assistant side trolley where we have 3-way syringes and the suction, most important. So we are not supposed to neglect these contact areas as well. So as we mentioned, we need to reduce the viral load. The viral load can be reduced with sterilization of all your instruments. So what is sterilization is? A reprocessing of all the reusable instruments that have been used on the patient and they have been contaminated or potentially contaminated with saliva, blood and other fluids. So there are multiple ways by which we can sterilize. However, steam sterilization is the most effective and cost effective as well. We have other options like dry heat and chemicals, but generally moist heat is the best mode to do it. Generally, our staff can even confuse what is sterilized instruments and what is a sterile instrument. A sterilized instrument is something that has undergone autoclaving and which was not wrapped in any kind of envelope. And then it was after the autoclaving, fresh set of gloves are worn, packed it in a way that it can be used directly on the patient, or it has been kept in a sterile tray where you generally store your instruments. However, what is a sterile instrument? A sterile instrument is an instrument which is wrapped before being autoclaved, like we saw in the packets. Like packets are made and then they are put into sterilizer or autoclave, which is generally a vacuum sterilizer because that maintains its sterility. And then when it's to be used, you just directly open it. Or also a single use item that has been purchased from out, like a syringe, a needle, is a sterile instrument because they have been sterilized outside, they have been packed, and then you got it to your team. So that's what is different between sterilized and sterile. However, so I'm a consultant around in Mumbai and I see many clinics still have this water boilers and some small scale clinics and the assistants do tell me, sir, boilers the instrument they do. And I was like, no, boilers cannot replace autoclaves. Boiler is just to clean the superficial debris, but autoclave has its own role to play. Though there are many types of autoclaves which are available. So let's see some of the types. So there is class N, class B, and class S. So we never paid attention to what really these classes are for, but we'll see gradually. So class N autoclave is generally used to sterile only the solid structure instrument. They do not work on hollow instruments or the instruments which have been packed in packets, and they don't have a drying cycle. So in case if you have an N class autoclave in your clinic, then you need to put instruments open and only the instruments which are non-hollow, they can be used. A class S is somewhere between intermediate between the N and the B class. In this, you can put multi-layers as well as you can put packed instruments also. It has a single stage vacuum cycle in which the air is pushed out and then the sterilization process is started. However, B class is the state of art which is currently available as it meets all the guidelines which are required by the sanitary and the epidemiological departments. It can sterilize all kinds of instruments. However, class S also can sterilize your hollow instruments. Class B can also sterilize your hollow instruments. It's the most effective technique because it removes air from the chamber and it has multiple drying cycles as well. So that's where comes the cost. So B class, because of these multiple advantages of drying cycles, it comes at a cost. So in a nutshell, we have N, B, and S class. So B, of course, we saw that is the best in the option available, but S also should not be a big query. But N, when you have, you need to be careful about what instruments you are sterilizing in that. Of course, we all know this. We've been reading this and knowing this from our dentistry days that the wrapped instruments and the unwrapped instruments, what should be the cycle for autoclaving? So for wrapped instruments, we have 121 degrees Celsius for 15 psi for 20 minutes. And if your instruments are unwrapped, you just do a 30 psi cycle for 3 minutes at 134 and you are good to go. So many of us, we didn't know that this also exists. Like, is there a classification for instruments to be sterilized also? Like even I didn't know. So there are critical instruments which have been come in contact with blood and in the patient's mouth. That's where it comes to forceps, elevators, scalpels, bone chisels, burrs. We need to clean our burrs as well. Semi-critical, which comes to handpieces, tweezers, restorative instruments, and impression trays. And non-critical being some medication bottles, your light dot tips, glass slabs, cement, spatulas, instrument trays, and all that. So thanks to COVID again, everything is critical. Whatever's come in contact, whatever you touched around, everything has to be sterilized. How do we clean our instruments? Of course, if we go to our sterilization room and we see how our assistants are washing the instruments, we come to know we need to clean the visible debris with a toothbrush so that the steam which is in the autoclave, it comes in contact with these instruments and it gets sterilized. We need to wear gloves and do it. Eyewear, gown, mask, everything is important. Most important is take only one instrument at a time. One instrument, scrub, clean properly, and then the second one. So not multiple instruments, but single instrument. We have chemical disinfectants like Corsolex, which is most widely available as multiple options, Corsolex rapid, Corsolex ready to use. And so depending on what you purchase, you need to see the guidelines mentioned on it. If it's ready to use, it's already diluted. If it's rapid and smaller concentration, then you need to dilute it as per mentioned on the bottle. So what instruments can you put with chemical disinfectants are the heat resistant and heat sensitive instruments, like all the plastics, silicons, and rubber based all instruments you can use from Corsolex. Microscopes, most of us have in our clinic. We need to clean the surface of microscope with some solution. So Corsolex can be used on it. Multiple advantages, it's bactericidal, yeasticidal, it's fungicidal, sporicidal, virucidal, everything. But this does not replace autoclave. We cannot just put our instruments into chemical disinfectant and start using it for the instruments which can be used in, which can be sterilized in autoclave. Right? Ultrasonic cleaner, of course, we do have these also in our clinics. Mostly the boilers or the ultrasonic cleaners. Ultrasonic cleaners work more better because they're oscillating bubbles which are formed. And you can put Corsolex solution also in this, and you can see to it that the instruments have been sterilized and cleaned. You need to put open loose instruments. When they are loose, you can do it for a cycle of 3 to 6 minutes. You get bigger size ultrasonic cleaners as well, in which the entire cassette can be placed. Of course, the cassette should be having the holes for the water solution to pass in. Then you need to do for a longer cycle, that is up to 10 to 20 minutes cycle. So I recently hired a new assistant, and when I told her that put my handpiece for sterilization, that's what expression she had. Like, really, do you sterilize instrument? You sterilize handpiece also? So she's like, yeah, the previous clinic never sterilized handpieces. Yeah, we need to sterilize our handpieces as well. Not only cold sterilization, but see to it that when you purchase a handpiece, you can ask the dealer that I want to sterilize my handpiece. So how do I go about it? And once it is safe in autoclave, we can sterilize it safely. You can pack it in a packet like this so that the water does not enter directly, and does not damage our cartridges, but we need to sterilize our handpiece. Of course, we do get now such machines from NSK where we can, N3 I think is what they call it, where we can lubricate our handpieces and clean the entire channel inside. So these also come to our rescue. A little expensive, but we can invest for our own safety and our patient safety. In that, we need to make sure whether your handpiece mentions that you have to oil and clean it before autoclaving or after autoclaving or both. So when that happens, we need to label them like they have been only cleaned and they have been sterilized. So make sure the assistants are not manipulating the handpieces before they have been autoclaved. Loading of instruments, we don't have to just dump all our instruments into the autoclave. We make sure that the instruments do not overlap one on each other so that they are properly covered by steel from all these sides. We put them into cassettes or perforated trays, and then we select the cycle as per the autoclave which is there in your clinic. We need to shut the door or the lid of the steam autoclave tightly. We cannot overload and have any loopholes around so the steam escapes from there. Once the instruments are sterilized, once they are being packed, in case if you have an N-class autoclave, then you can pack it after the autoclave cycle is done with glove hands, and then store it where it's not getting contaminated again. So packaging and storing is also equally important. So this is what my assistant does. She's cleaning individual instruments, and she has been told that she's not supposed to use multiple instruments at a time. So that's how she'll clean first, and then they'll be dipped into the wash. Of course, the soap has to be out, and then they are dipped in Corsolate solution, in which they stay for roughly 5 to 10 minutes till the time they have been chemical sterilized. Once they have been chemically sterilized in Corsolate solutions, they'll be removed and put in ultrasonic cleaner, where we have a cycle of 20 minutes. Of course, the burrs and the files also go in ultrasonic cleaner. And once the cycle is done, they are being removed, they are being dried so that we don't have any fluid sticking on it, so that they don't rust. And individually, everything is packed in pouches. And once the pouches are done, they have been put in the autoclave. So not to forget the waste that we generate, that is also one of the means to spread infection in our clinic. So as per the records, we are somewhere, dentistry gets around 3% of the total biomedical waste is generated from our field. We of course have anatomic and non-anatomic waste as well. We have chemicals that we use, we have these sharp instruments. We'll see how do we discard all of these gradually. So non-anatomical waste is supposed to go in yellow bags. We get these color-coded bags directly from our biomedical waste guys, or now they're freely available on Amazon and local shops as well, where you can tell a dealer to get it for you. So yellow bags are for non-anatomical waste, where you put in the swabs, the dressings, the gauze, the cotton, the aprons, the gloves, IV lines. Of course, if some of us have a minor OT setup, then we can put into the IV lines also in that. Some metallic parts and the syringe bodies, not the needle, the syringe bodies go into the yellow bag. The anatomical waste is all the fluids that we have, the blood, the saliva, some tissue organs, and that's all there. Medical apparatus in which the swabs have been soaked in blood, the drapes, everything goes into the red bag. So anything that is visibly contaminated with blood or body fluids go into the red bag. So we need to make sure that we are segregating the bags for betterment of the biomedical waste guys as well. Very important to discard sharp instruments safely. As we saw, non-PVC boxes, we do get such kind of heavy plastic boxes where we can discard our needles and syringes. We can mutilate our needles before so that it's even more safer. All the glass syringes, ortho wires, everything, blades, everything goes into sharp boxes, and the box contains 1% sodium hypochlorite solution, which after 2 days you need to replace. It's not that you filled in once and for the entire month you let it be there. And even when you hand over these sharps to the biomedical waste guys, pack it separately and hand it over to them so they can also be careful about it. Some of us are still using X-ray films in our clinic. So the X-ray developer and fixer, I just happened to meet a friend who uses this, and I asked, what do you do for the developer and fixer? How do you discard? So like, just put it in the drain. No, that is absolutely wrong to put it down the drain, as it is biohazardous. So we need to label them separately, like we label before putting into our X-ray chambers. We need to label them even when we are changing it, because if you mix the two, if you mix the developer and fixer, then it becomes quite hazardous. And these solutions, you can either give it to your biomedical waste guys, or you can give it to the dealer back, so they can treat it again. They would remove the silver out of it. Of course, that is also a good income for them, and then they would discard the rest of it. So maybe you return it to the dealer, or you can give it to the biomedical waste guys, but separately. But you are not putting it down the drain. It's really bad for our environment. Lead and mercury, since we are using films, we are generating a lot of lead foils from the X-ray pads, and most of our assistants are surely putting it into the dustbin. No, we are not supposed to be doing that. That goes wrong. We need to keep it in a separate pack and hand it over separately to the biomedical waste. Amalgam, if we are using, then we need to have capsules of amalgam which are agitated and used, so that we don't waste amalgam or we don't drop the amalgam while being mixed, and the mercury is not open anywhere around. If you are still using the powder and mercury liquid separately, see to it that the mercury lid, the bottle lid is tight and you don't have vapors around, because that's harmful to you only. Also, if you are extracting teeth which have amalgam fillings, then they should be kept separately. How do we discard it? Okay, we've understood, we put in yellow, we put in red, but then how do we discard it? How do we tie it? So we don't tie it like we normally tie our plastic bags with a dog ear method. No, we need to take it all around the neck of the bottle and tie it tightly. And we see to it that our bag is not filled up to the brim, and then we tie it with a thread or something. The bag should be only somewhere between half to 3/4 filled, so that the rest of the part can be used for tying the knot and can be handed over to the biomedical waste guys. Don't accumulate waste for longer times in your clinic. That's a source of infection as well. So we need to call them regularly and get it discarded. So there I conclude most of the things seen, heard. I'm sure we were following all these protocols, but some reminder, some eye opener here and there should be beneficial to you. We need to stay fit and healthy. As we saw in the trial, that we need not be a susceptible host, so and build our immunity and stay vaccinated. I'm sure most of us are now vaccinated, but we need to be vaccinated and healthy. Don't let it be only on your assistants. Take things in your hand. You should be equally responsible for maintaining disinfection and sterilization in your clinic. It's eventually your clinic. Washing hands, as mentioned, is very important. We have multiple germs in our palm which are not seen, so we need to scrub properly and wash it. Be comfortable in whichever PP you are wearing, whether it's the 90 GSM, 60 GSM, 20 GSM, or whichever is your choice, you feel you're protected in, you need to wear it comfortably. Oh, this is not the slide which has come back, but yeah, washing hands repeatedly between every patient is important. So we need to wash hands and scrub really nicely with soap. Whichever choice of autoclave we have, we need to do proper cycles, pack our instruments properly, keep our instruments safely so that they're not recontaminated and they are ready for use. Take real care of sharp instruments. We need to be safe. We need not have cuts on our hand. Our assistants need to be safe. So see to it that after the local anesthesia is given or a blade is used and procedure is done, we should make sure that the blade is removed, the needle is discarded properly, and it's not hurting anyone. And our waste has to go safely. So our biomedical waste guys are also not being infected or affected by all the material that we use. That's where I conclude. Thanks to my mentors for opening my eyes to everything and helping me through setting up of my clinic when I was starting up. That's my clinic. You would see around on the social media as well. And of course, people around can drop it. Thank you so much. Thank you so much, IDA Cochin, to give me this opportunity to talk about a very basic topic, but I hope I have justified it today. Thank you.
Thank you very much, sir. It was a very good discussion we had. Actually, we could brush up many things. Dr. Deepak. Dr. Deepak.
Yeah, yes, sir. Yes, sir.
There are no questions actually. So can we conclude the meeting, or you want to ask something?
It's a really basic topic for everyone.
There
to
is some
get into.
audibility problem.
Am I not audible?
You're audible, doctor.
Some audibility problem is there, sir.
No, I think there is a network issue in your end.
Am I audible?
Yeah, my side, sir.
Yeah.
So, then you please carry on, sir, because there is some audibility issue. I think it's not audible.
Okay, it was a very informative topic. Thank you all the participants who attended it. I hope you all had a brush up through what should be done in your clinic to protect yourself as well as your patients, especially during the COVID time. Even otherwise, we have to follow all these things. And as you said, doctor, it is a very valid point that we continue using the face shield, etc., to protect ourselves from the aerosol part.
Yeah, we should. Whatever procedure, we need to have our face shields on. We are examining, we are drilling, or just extracting a tooth, which is quite atraumatic, but we need to protect with face shield.
Doctor, I would like to ask you a question. In our place, it is usually the patient wants to touch the teeth and say that this is the teeth which is having a problem. You are also having the problem that problem in your place.
Yes, we do have. So what I tell my patients is that we'll give you the tooth to touch and to take home as well, but let us first clean with hydrogen peroxide. We run it under soap water and put it in hydrogen peroxide, clean it nicely and pack it in the, the boxes that we get from our labs with the crowns. We pack it into that and give it to the patient. We tell them you can have it yourself. And when you want to discard it, you can discard it safely. Because I do have some community patients who do believe in burying their teeth as well. So I need to hand over to them as well. So if patient does not want to take, of course we discourage it. But then some do have their community rules. So then I have to hand it over to them.
No, my concern was something else. It is the patient would like to tell us when they want to explain which teeth is having a problem. They would like to touch and show.
That way. So we generally discourage that because once the apron has been put on the patient, we tell them not to get hands above the apron. So maybe if they really get it up, they want to point out the side or something, then they would just point here outside their mouth. They would just touch their skin. But other than that, I generally discourage patients putting their fingers in the mouth and pointing out something. So I wouldn't allow them to do that.
Doctor, we are having a question from Dr. Vidya. What is the fumigation protocol you follow?
I don't fumigate in my clinic. Of course, I have seen friends' clinics where fumigation is done with any solution that is available outside, be it sodium chloride, hypochlorite or not. There are rusting of the operating chair or the patient chair everywhere. So I do not fumigate my dental room or my minor OT. I just use UV tower between every patient. Like we saw in the video also, as the patient walks out, we let all the instruments, entire setup be there as it is. And we start the UV light for 5 minutes. And after that, it's even safe for my assistant to go in and transport the instruments to the sterilization room also. So I'm not fumigating my clinic and I'm doing it with UVC tower.
We are having one more question. Will rinsing with iodine solution help to reduce the viral load before an aerosol procedure?
Before any procedure is what even we follow at my clinic, that once the patient is seated on the chair, we tell the patient to rinse the mouth with mouthwash solution which has povidone iodine. And then the patient sits on the chair and we glove up and we see the patient. So yeah, mouthwash rinses before anything, like be it a consultation, be it a filling, be it an extraction, be it crown cutting, aerosol, non-aerosol, we need to tell our patients to gargle once with the mouthwash.
And do chlorhexidine do good, or only providine iodine will do?
Both
good?
are okay. We can use either of them, but it has to be concentrated. We don't dilute it.
Which is better, doctor?
Chlorhexidine is better. I would prefer chlorhexidine. Personally,
Okay.
if I'm given to be on chair, I would prefer chlorhexidine.
Okay. Thank you, doctor. Thank you very much. That is all for the questions. We had a very wonderful section. Thank you very much, doctor.
Thank you so much for inviting me.
Thank you, sir.
Thank you.
Thank you,
Thank you.
Vineet sir. It was really a good session. Thank you so much.
Thank you.
Thank you, doctor.
Thank you.
Good night. Good night, doctor.
Good night.
And thank you all the participants who attended the meeting. Thank you.
Okay. Thank you.